Iros sentando por adelante, por favor, no tengáis vergüenza, para adelante. Cuanto más cercanos, mejor, más aprenderemos.
So good afternoon. On behalf of the Hospital del Mar, the Department of Medicine and Life Sciences of the Pompeu Fabra University, and the Jean Bernard Student Surgical Society, we welcome all of you to this very, very special session. We welcome today Professor Henry Marsh. It's really a privilege having Professor Marsh with us today. And I think the title of his presentation, Their Lives in Our Hands, speaks for volumes. I think that the topic he's going to address today is a priority for our two institutions, the hospital and the School of Medicine, because we have arrived at the time, we have reached the time where we have to think about returning the soul to medicine. We are living moments where part of our practice is without sorrow. And I think that taking into account the importance of the human components in our relationship with our patient, in our institution, is very important. So the reflection of Professor Marsh, I think, are going to be very important today for us. So I give the word to Dr. Jesus Lafuente that will introduce Henry Marsh.
Thank you to everybody. It's a great pleasure for me to introduce what once was my boss for a little while, then became a colleague, and now I believe became my friend. Henry Marsh is a professor of neurosurgery. He did his training in London, as well as his medical school. But before that, he studied politics, philosophy, and economics at the University of Oxford. And he was graduated with honors, of course. We never expected less. Okay. And he went to work to Atkinson Morley, one of the biggest centers in neurosurgery, which then converted into St. George's Hospital. But one of the things that we became close friends with, it was because his global neurosurgery input. He is very dedicated to help in countries with little infrastructure in neurosurgery, and for that reason, he has had several productions at the BBC. One of them, maybe you remember, the World of the Surgeon, I believe was the title, in 2009. And this also gave him a winning prize at the Emmys. And also he's been dedicated to work in Ukraine, Azerbaijan, and many other countries. And I respect him not only for being a great neurosurgeon, but also for the work he does in these countries, particularly now. As we all know, Ukraine is under siege, and he still goes there to lift their morale on the surgeons there. So it's a great pleasure, and I'm very pleased to see Henry Marsh in our hospital here, and I'm sure you will all be enjoying his lecture. We will follow his lecture with a round table, and we'll have some questions, and we'll open to the floor. So if anyone wants to make any question in Spanish or in Catalan, we can translate it to him with no problem. So Henry, thank you very much again, and welcome.
Good afternoon. I'm really very happy to be here. It's a great privilege. And I've always been very proud of the fact that my books have been very successful in Spain. And that, as a writer, is obviously very pleasing. It's wonderful to be a doctor. I always felt that. I felt that when I was studying to become a doctor. I feel that now in retrospect, even though I do very little clinical work now, although I still teach in England and do some operating in other countries. It's profoundly meaningful and rewarding. If you think of some of your friends who spend their days sitting in front of computers, making lots of money for banks, things like that, But when they look back on their lives, what have they achieved? As doctors, we have this extraordinary privilege that what we do is so important and so meaningful. We have this profound responsibility for the lives of our patients. And it's not just their lives, but the quality of their lives and their states of mind as well. It's extremely interesting. Maybe some people don't find it interesting, but I've always found medicine, anatomy, physiology, psychology, quite extraordinarily interesting. And again, a privilege we have as doctors is we are never short of funny, interesting, shocking stories. Because ultimately, our work as doctors is all about the stories of our patients' lives. We get social status and respect. There are not many countries in the world where just by virtue of being called a doctor, people immediately look up to you and respect you, even if you don't deserve it. And it's usually well paid. I mean, what's not to like about being a doctor? Well, it can be very difficult. Now, what did I think was difficult about being a doctor when I was a young doctor many years ago? There is the young Henry Marsh. What do I think now, old and wise, many years later? Well, I'll tell you what I learned. And I was a brain surgeon. What did I learn? The operating is easy. Everything else is difficult. Brain surgery, easy? How can that be? Well, everything is relative. But looking back on my career, where I struggled, where I made mistakes, where I did not do well, it was usually not the operating. It was the decision-making, the relationship I had with my colleagues, with my patients, with the staff. These are the difficult areas of being a doctor, though it is not something perhaps you realize at the beginning of your career, where you see it as so much as a technical problem of having to learn lots of facts, learn surgical skills. I see my medical career, and I think this applies to all doctors, is like being on a tightrope. You're trying to find a balance. And if you remember that great song by B.B. King, you better not look down if you want to keep on flying. And when you're on a tightrope, you don't want to look down too much, or you'll lose your balance. And now that I am off the tightrope, having retired from operating, at least in England, perhaps I can see some things more clearly than I could not see at the time, when often I had to wear blinkers and have narrow focus vision in order to get through the day. So everything else, these are the problems I faced as a neurosurgeon, but I think they face all doctors. And there's a list. Some of them I will discuss, some of them I do not have time to talk about. We have to find a balance between compassion, caring for our patients, and being detached, clinically scientific. We have to find a balance between being ambitious individuals, big egotists, particularly surgeons, and as being members of a team. And if there's any message I want to get across to you today, it's about the importance of seeing medicine as a team effort. We have to find a balance between our conscience for what is best for the patient in front of us, and sometimes having to compromise for the sake of the department, for the sake of your colleagues, almost to be obedient to the management in the hospital. If you do private medicine, you have to find a balance between, is medicine a vocation or is it a way of making money? Obviously, it is a bit of both, but again, it is a difficult balance sometimes to establish. And again, very importantly, we have to be self-confident, particularly perhaps as surgeons, but in all branches of medicine, we have to give our patients clear, helpful, strong advice and reassurance. So we need to believe in ourselves, but we also have to be very, very self-critical. It is the nature of medical practice that things keep on going wrong. Patients come to harm, maybe simply because of the natural history of the disease. But every day we will see things working out badly. And it is critical that when we see a bad result, we think, what could I have done differently? What will I do differently next time? And the problem is that's very difficult, because that means we have to criticize ourselves, and that conflicts with our need for self-confidence. And we have to find a balance when talking to patients between being honest and sometimes having to pretend. We have to give hope to our patients, and sometimes that is very difficult. And finally, we have to find a balance between work and between our life outside the hospital. My generation of surgeons, it was all work. I had very little life outside, and I regret that in retrospect. I'm lucky that I still have a very good relationship with my 3 children, even though they saw very little of me, because I always put work first. Compassion versus detachment. Well, if we are too involved emotionally with our patients, we will suffer burnout or compassion fatigue. We will become stressed because we cannot separate ourselves away from the suffering we see, and we'll make bad decisions as a result. I tell at least one story in my first book of a patient where I should not have operated again. I should have let the patient die. I should have said, it is time to stop. But I couldn't do that. I'd been looking after this young man for so many years, and I operated again and made everything worse, and he died much worse than would have been the case if I'd done nothing. That is an example of where compassion can actually make things worse. But at the same time, we can become too detached, less stressful, but we become dehumanized. And again, we'll make bad decisions, because so many decisions in modern medicine are not about saving the life. If we operate, the patient will live. If we don't, the patient will die. So many operations are about quality of life. And we cannot tell our patients what they should decide. Only our patients and their families can judge what is good or what is bad for them. Our role is to advise them what the options are and to maybe push them a bit in what we think is the right direction. But if you are too detached, if you cannot feel the anxiety, the problems, the pain our patients and their families are feeling, we will not help them make the right decision. We see terrible things in neurosurgery, brain scans on the left of fatal hemorrhages, a grotesque case of arrested hydrocephalus I saw in Sudan many years ago. We have to see terrible things. We have to witness terrible things. We have to learn not to let it overcome us, but not to lose our humanity in the process. And I ask Jesus to translate this. You can all read it. I will not read it out to you, but I'll say in English, the traditional medical model in English was called detached concern. You were concerned for the patient, but you were emotionally detached. And many modern critics say this is the wrong model, and instead we should have engaged concern. We should be emotionally involved with our patients. Now, I came across this article just a few weeks ago in the Financial Times newspaper about an American family practitioner called Rita Charon, who has started a school of medical teaching called narrative medicine, where you stress, you emphasize that what medicine is about is the stories of our patients. It's not just about a broken leg or a heart failure, it's the patient as a whole. And she says something very interesting at the end of the article. And this is an example of the way that the doctor-patient relationship is not like any other relationship in human life. If you're walking along the street and somebody drops something and you pick it up and give to them, they will smile and say thank you, and you'll feel quite pleased. If as a doctor, a small act of kindness to your frightened, anxious patient is completely different. And as she says, there is something heartbreaking about the disproportionate, the huge gratitude a simple act of kindness, a simple intervention will produce. Just holding the patient's hand, helping them put their shoes on. Little acts for us are nothing for our patients because they are in such an inferior position to us. This is enormously important. They will feel better. I cannot promise they will get better, but they certainly will feel better, and you'll have a much better relationship with them. Again, in hospital practice, sit on the patient's bed. I think sometimes this is not allowed on the grounds of infection control. But again, a simple act of human kindness like that, which for us is nothing, is hugely important for our patients, rather than the traditional model of all the doctors in white coats standing around the patient, lying vulnerable, half naked, surrounded by all these dressed up tall people in white coats. Never forget that being a patient, and I speak as a patient because I have advanced cancer, is frightening. It's humiliating, having tubes, lines stuck up every hole of your body, and it's degrading as well. And that is a universal feeling for almost all patients, which nobody ever pointed out to me until halfway through, until I became a patient myself. But there is a problem. The more we care for our patients, the more it hurts when things go badly, and especially if you feel it was partly your fault, your responsibility. And this is a huge emotional barrier which is very difficult to overcome. We become detached to protect ourselves. Now, it depends on what sort of medicine you do. But all branches of medicine, with the exception perhaps of pathology, we all have disasters. Psychiatrists, I have friends who are psychiatrists, they are haunted by patients of theirs who committed suicide. Family doctors miss a diagnosis of cancer. Neurosurgeons like me have many, many complications, but that is the nature of the work. But all doctors, we have to learn to cope with bad results and not become too detached to protect ourselves. And also empathy, feeling what our patients and their families feel. It's hard work, it hurts, and we tend to avoid it. It's not easy. So although it is so important to keep our kindness and compassion, it is a difficult balancing act. What will determine how we find a balance between, in different words, kindness and callousness? Well, the example of senior doctors is very, very important. And as students, you're in a very good position to look at the doctors and think, is that how I would want to be talked to? Is that how my family would want to be talked to? Once you are doctors yourselves, and you have to say yes sir, no sir, and be good servants to the senior doctors, it is more difficult to have this slightly critical view. Just as now as medical students, you can sit down with the patients and actually learn from them what it is like to be a patient. Once you are doctors in white coats, there is a sort of glass wall between you and your patients. And it is much more difficult to understand what your patients are going through. As students, you have a wonderful opportunity, if you wish, to talk to patients as equals, as fellow human beings. National culture, if you work in former Soviet countries, as I've done, where all doctors were employed by the state, you could not complain or sue doctors. This was very corrupting and terribly bad for medical manners and bedside manner, because patients had absolutely no way of complaining or reacting to bad behavior or terrible complications to operations. I've seen many patients with disastrous post-operative problems where the surgeon involved simply refused to see the patient again. Go away, see somebody else. Now that is a question of national culture, so that has an effect. Your personality, some of us are better at opening up with our patients than others, and I know some neurosurgeons who are slightly psychopathic, not completely psychopathic, but it can attract psychopathic personalities. There's a long list of what constitutes psychopathy, but one of the defining characteristics is lack of empathy, inability to feel what other people feel. And your training and education, which is why you have a wonderful opportunity here in your hospital, because people are trying to make you into better doctors, not just technicians. And your experience, and this is a problem you face. It is possible you may already have had some experience of ill health or members of your family, but most healthcare is handed out by fit, healthy young doctors and nurses who don't really understand what it's like to be old, to be lying on a trolley, pushed along corridors. It's quite difficult. You have to make a leap of the imagination to try to realize that your world, your life, is so very different from what is happening to your patients. It is jammed. Why has that happened? Anyway, I've got it going again. Thanks. So now the next point I want to talk about is this question of team working. As doctors, you are part of a chain, and the strength of a chain is the weakest link in the chain. As doctors, we think, well, we're very important. We're at the top of the chain. We are very strong. But actually, the strength of a chain is the weakest link. And that chain is the porters, the cleaners, the pathologists, the physios, the nurses, the doctors. All these people are part of a chain. We are nothing without all the other members of the team. I have trained probably hundreds of neurosurgeons. And one of the most important ways in which I tried to understand whether there would be good senior surgeons or not was seeing how they related to the other staff, to the nurses, the cleaners, the porters. If they did it badly, on the whole, it was a sure sign they would not be very good, because human relations are such an important part, even of brain surgery. But the problem is, of course, surgery, particularly brain surgery, attracts ambitious risk seekers with big egos, which I'm afraid did apply to me to a considerable extent 40 years ago. And of course, there would not be 180 dead bodies frozen on Mount Everest if climbing Mount Everest was safe. What attracts people to Mount Everest is the danger, the risk. And although that does not apply to all doctors, most doctors do not want to be surgeons, and very sensibly, most surgeons don't want to be neurosurgeons. But there is an element of risk which we find attractive, and we have to learn to master that and master our surgical egos. Perhaps you have seen the Walt Disney Snow White and the Seven Dwarfs. There is the evil stepmother who every morning looks in the mirror and says, "Mirror, mirror on the wall, who is the fairest of them all?" And then one day the mirror says, "Snow White over there with the dwarves," and she's madly jealous. As surgeons, we're all a bit like the evil stepmother. We're all anxious. Actually, we may have another surgeon who's getting better results than we are. And this anxiety often leads to jealousy and discord and can make surgeons bad at cooperating with colleagues. So jealousy and insecurity actually is part of the surgical ego and often shows itself as arrogance, self-importance, denial of complications and problems. Now, this is a very good book written by an English writer called Matthew Syed. I used to be rather skeptical of making comparisons between the aviation safety business, because as you know, flying in commercial airplanes is fantastically safe, is one of the safest ways of traveling, and comparing that to medicine. And he describes in the book various famous aeroplane disasters, of which that was one. The pilot was coming into land in the dark, in rain, the radar wasn't working, and the senior pilot thought he was higher up than he actually was. And on the black box tape recorder, after the crash, you can hear the co-pilot saying 200 meters, 150 meters, 100 meters, 50 meters, and then they're all dead. And the lesson Korean Airways took away from that was what's called crew training. You had to train the co-pilot and say, hey, boss, look out, you got it wrong. And you had to train the pilot to listen to his co-pilot. And that is an example of where team working is so important. But there is, of course, what the lesson I took from reading Syed's book, I'm sure it's been translated into Spanish, is that highly trained, highly skilled pilots can make terrible mistakes. And all of us as doctors will make mistakes. And depending on what branch of medicine you're in, it'll depend on just how bad the mistake is and how often you make mistakes. And the point is, speaking as a surgeon, surgeons are no different. But there is a critical difference between surgeons and pilots. If you're the pilot, you probably will be killed when you crash. This means two things. Firstly, you have a serious interest in making things as safe as possible. Secondly, the pilot dies, that's the end. The surgeon does not die after he has killed a patient. He has to live with the disaster. And that is a psychological problem, coming back to the self-confidence, self-criticism I was talking about earlier. And one of my favorite surgical quotes, I wish I'd written it myself, was by the French surgeon René Leriche, who said, all surgeons carry within themselves an inner cemetery, because we've all made mistakes. And it's a place to which we must go, even though it's so difficult, to consider our mistakes and learn from them. And although this is about surgeons, this applies to all doctors to a greater or lesser extent. Now, being honest about failure and visiting our inner cemetery, as Leriche called it, is painful. And we try to avoid it and often try to hide it. We can hide it from our patients. We say, well, this happens all the time. Something went wrong with the operation, but you tell the patient, well, blah, blah, blah. And patients usually accept it. You can hide it from our colleagues, and we can hide our mistakes, most importantly, from ourselves, and deny that we could have done better. But the problem is we learn more from failure than from success. So in fact, good doctors make mistakes, but learn from them, and even better, discuss them with their colleagues. And there's another very good book, I haven't got the slide here, by the American surgical writer Atul Gawande, called Complications, which discusses this problem. As he says, the problem is not that bad doctors make mistakes, but good doctors make mistakes. Now that's the WHO checklist, which we're all supposed to use, and we do in my hospital, I'm sure you do here. I have some criticisms of it, but the idea is a good idea, just like before an aeroplane takes off, the pilot and co-pilot have a checklist, so we should do the same before doing a dangerous operation. But when it was introduced to my hospital years ago, I was opposed to it. I was cross and grumpy until my anaesthetist pointed out to me I once had started a craniotomy on the wrong side. And I said, well, and I couldn't deny it. So why didn't I like the WHO checklist? Well, I didn't like to think I might make mistakes. To have that checklist was a reminder to me that actually I make mistakes. And when you walk into the operating theatre, you don't want to feel I'm going to make a mistake. So again, it's this problem of a balance between self-criticism and self-confidence. And to be good doctors, we sometimes have to pretend to our patients. We have to give patients hope. Hope is one of the most powerful drugs we have. It is amazing what we as human beings will put up with if we have hope. And it is our duty as doctors never to lie, but always to give patients hope. And that sometimes is a very difficult balance to achieve. But talking to patients if they have a serious disease, and I had many of these breaking bad conversations, as we call them, breaking bad news, as we call it in English. It's very difficult. The family and the patient never telephone you next day and say, Mr. Marsh, you did that very well, or you did that very badly. So it's very difficult to learn how to do it. But it is a very, very important point. And I have not got time to talk to you about my views about how to break bad news. Patients want certainty. When I was diagnosed with cancer, I wanted to know what will happen to me, Henry Marsh. But of course, my oncologist doesn't know. In effect, he says, well, if I had 100 Henry Marshes, 75% will be dead in 4 years or whatever. But no doctors know exactly until the very end. But as patients, we want certainty. And again, one of the difficulties we have talking to patients is being honest and not being too certain, but somehow giving them confidence and trust and faith. Now, there's a great book. Trivers is one of the great figures in evolutionary biological theory. He was one of the founders, along with some other biologists, of the selfish gene theory, which Richard Dawkins popularized in his Selfish Gene book. And he wrote some years ago a very, very entertaining book on deceit and self-deception. And he asks a question. Deception is everywhere in nature. All of us, all animals, are part of a food chain, either as predators or as prey or as both. And so deception is everywhere. But human beings are unique, as far as we can tell, in our capacity for self-deception. And Trivers, being an evolutionist, tries to explain this on an evolutionary basis. Why has evolution given us this tremendous ability for self-deception? And he says it's because self-deception makes us better liars, and therefore we are more successful. And you don't have to look very far in the world to see the truth of this. But in fact, the same applies to us as doctors. We have to deceive patients to a certain extent. And we have to, particularly when we're young doctors, our patients come and see us when we are young doctors, they have to believe that we are better than we know we really are. And it's easier for us to deceive them into thinking we really are very good by telling ourselves we really are very good. So there is nothing more frightening for a patient than a frightened doctor. And we must pretend to be as good as our poor patients hope we are, and we never make mistakes. Nobody ever told me this, but you learn it immediately. You become a doctor. You cannot show your feelings to your patients if you're anxious and frightened. And often we are anxious and frightened as doctors. Throughout our careers, I still, well, not now, but even at the end of my career, if I had a major operation to do, I would always be anxious. It's very important. If you're not anxious, you'll probably not operate as well as you should. It is part of being a doctor, is it can be frightening and painful, but we mustn't show it to our patients. And as I said, following Trivers, it is easier to deceive our patients if we deceive ourselves into believing that we really are as good as they hope. That becomes easier as you become more senior and more experienced. And I found I had a much more relaxed relationship with my patients as I knew that actually I was quite good and I knew what I could do and what I couldn't do. But it takes quite a while to learn that. Now that's the Muller-Lyer illusion. You can look at those two arrows for as long as you like. You can never see them as being the same length. And that's relevant because Kahneman, the great psychologist who died recently, in his wonderful book, says that when we think, we also are hardwired to make mistakes or misperceive things, just as we cannot see the Muller-Lyer illusion clearly. And there's a long list of these so-called cognitive biases, unconscious mechanisms that distort our judgment. And the point is, medical decisions are the risks and benefits of treatment against the risks and benefits of no treatment. But these are probabilities, these are not certainties. And all Kahneman's work with his colleague Tversky showed when we have to estimate probabilities, our calculations are subject to many unconscious biases, and we get things wrong. And there's a long list of them, and I haven't got time to talk about them, but it's well worth looking at that book. Now, the point is, the conclusion, and I'm reaching the end of my talk now, is that other people are better at seeing my mistakes than I am, and I am better at seeing their mistakes than they are. And so teamworking, and in English the word teamworking conjures up images of bureaucrats and management meetings and terrible stuff like that. So I prefer the word being a good colleague and having good colleagues. And here I'm not talking about the chain of porters and cleaners and nurses. I'm talking about your immediate medical colleagues in your department. You will make better decisions if you have good colleagues. So you can discuss difficult cases. You can discuss complications. You will make fewer mistakes because your colleagues will see my colleagues will see my mistakes more clearly. And I could show you many slides of patients I caused terrible harm to because I was too proud or too stupid or too confused to ask for the help of a colleague who would immediately have seen what the problem was. But I couldn't see it because of all my biases, and I found it so hard to accept a wonderful operation I'd done had gone so terribly wrong. And it's better for your mental health and work-life balance. Medicine can be very stressful sometimes. Sometimes it's wonderful, sometimes it's terrible. Only your colleagues understand how stressful it can be. And to work in a happy department, as I do in London, I still teach in my neurosurgical department, where the basis of my relationship with my surgical colleagues is friendship, is enormously important. We all know medical departments where the doctors all hate each other, and this is very, very bad for your mental health. And it's also good for your work-life balance. If you have really good colleagues, they can look after your patients when you're away. It makes life much, much easier. And it's better for training. The trainees are much happier to work in a happy department where the colleagues are good. But the first rule about having good colleagues is you will not have good colleagues if you are not a good colleague yourself. It is what the philosophers call necessary but not sufficient. If you're unlucky, you may be a good colleague, but you still are some bad colleagues. So the work-life balance, very simple. Our patients want us to be 100% devoted to them. But the trouble is our families want us to be 100% devoted to them as well. And we do not have 200% of devotion to hand out. So that is another problem which is part of the difficulty of being a doctor. Now, there are many, many different branches of medicine. I can make a long list, but I want you to read the bottom line. They are all equally important. I do not like, particularly in America, the view that neurosurgery is the sort of acme, the peak of all human endeavor, and neurosurgeons are gods. It's complete bullshit. Neurosurgery is just another branch of medicine with its own particular problems and difficulties. But the actual operating is all about experience and practice, etc., etc. Very briefly, I could not have been a family doctor. I'm too impatient. I like using my hands. But there was an extraordinary paper 2 or 3 years ago from Norway, which has a very strong healthcare system, very strong family doctor system, and being a small country, 4.5 million population, they can collect statistics on the entire population. So this was a study of 4.5 Norwegian patients. It's a large number. And they showed that patients who'd had the same family doctor for more than 1 year lived longer, went to hospital less often, and had fewer call-outs at night. And the longer you have the same family doctor, in simple terms, the longer you live. There was a 25% reduction in mortality comparing the less than 1 year, more than 1 year group. And as I said, fewer visits to hospital, fewer call-outs, much, much cheaper, would have saved a lot of money. And do not think that being a specialist is the be-all and end-all of being a good doctor. All branches of medicine are equally important. That's the child I operated on just before the pandemic in Lviv. I'll be in Ukraine next week. Child of a 2-year-old child of a benign pilocytic cerebellar astrocytoma tumor. And then I was showing my colleagues how to do the operation. I was teaching. They'd just got a new operating microscope from Canada and did not know how to use it. What a privilege to stand around the bed of a 2-year-old child whose life you have saved. That's fantastic. By that stage in my career, I did not feel like a Tarzan. I just felt great relief that the child had done well. But the point of the story is the next child I operated in that hospital died horribly, and through a mistake I made to do with the post-operative care. And although in brain surgery the triumphs and the disasters are very obvious, we all in medicine, we have ups and we have downs, and the critical thing is to learn from them, to talk about them, to discuss them, to try to overcome the difficulty we have to think critically of ourselves. That's the Children's Hospital Akhmadit in Kiev. I was there just a few weeks before the Russians, in their typical way, bombed it with a missile. I've been going to Ukraine for many, many years, long before the war started, and I'm going back there next Tuesday. But the point of this is, again, as doctors, is one of the few professions where we are part of an international brotherhood and sisterhood, and that is also a great privilege, and also why I'm so happy and proud to be talking to you as my Spanish colleagues here in Barcelona today. Thank you very much.
Thank you very much for this wonderful lecture. I'm happy to see that the room is full, so people care. And now I'd like to invite the speakers and to do the general roundtable, so we can ask some questions about this very important issue, medicine. And I'd like to introduce, well, Henry Marsh. He's been introduced already, so please have a center seat, please. Jonathan McFarlane is a humanist. He's president of the Doctors as Humanists. Please welcome from the UK too. Although he lives in Mallorca, he's one of these very clever English that was born in a fantastic country but lives in a better country, I think. Manuel Pera, we all know here, is a professor here in the university and a general surgeon, upper GI specialist. Please, thank you. And last but not least, a representative of the students, Alex Godot, who's been involved in the Jim Bernat Student Society. Alex, thank you for coming. I have to say he was a student with us. He's rotated with neurosurgery and the department, and he wants to become a neurosurgeon. So there you go, Henry, another one of the family. So I'd like to start by a quick question to Henry Marsh. Wonderful, you touched, I think, all the aspects of humanism about the medical profession. I would like to ask you, we saw the picture of you in 1978 and the one in 2017. So you've gone through a long period during your career, and perhaps this has given you the opportunity to find out what are the things, comparing before and after, the doctors have improved at, and what are the things you think the doctors have become worse at?
Well, I mean, each country has its different problems. The National Health Service in England has been very under-financed, lack of money for a long time, and too much management has been introduced instead of investment and spending money on more hospitals and equipment and more doctors and nurses. Things have changed a lot, some for the better, some for the worse. 40, 50 years ago, the doctors in England on the whole were like gods. Nobody questioned their judgment. They rarely discussed cases among each other. They were each a sort of monotheistic religion of one. And there were very few of them. I mean, I was one of 3 senior surgeons when I became a surgeon a senior surgeon in 1987. And I was operating 4 days a week, which is a lot. I was doing hundreds of operations. That has changed profoundly. There are now about 12 senior doctors in my department. They all do much less operating than I did, but they all specialize more. So on the whole, I think the quality of the operating is better because of specialization. On the other hand, I think in many ways the work has become more stressful because there is more management, there is more litigation, there is more criticism in the media, and you have the social media now reporting on the doctors. So it was easier 40 years ago because nobody ever questioned your judgment, but you worked very, very hard and very long hours. Now my colleagues don't work very hard, but the work is more threatening in a way because society has changed.
Yes, thank you. I think it's a good point that the paradigm has changed dramatically. Before was to save the life. Now they not only want to have the life saved, they want to go back to work and enjoy the family business. Professor Jonathan McFarland, as a humanist, what do you think is the humane quality of the specialists now that, of course, as mentioned by Professor Marsh, they've been under a lot of stress due to increased stress through the media, through the patients. Now, as Henry Marsh was saying before, patients saw you appear and they bowed you. Now they are very demanding, they expect much more from us. And has this affected the humane take from surgeons or doctors towards the patient and families? What do you think?
Well, it's a very, very interesting question. I still have the feeling that the majority of students are being trained to be good technicians. The majority. I think here in Pompey Fabra is an exception. But I think there's also a trend to bring in the humane ideal, let's say, into medical training. Whether the surgeons, I think also Professor Marsh made a very interesting comment about Rita Charan, who's, let's say, the guru of narrative medicine, and she talked about stories. And the stories, I think, are a good way of connecting the medical professional with the patient. And I was wondering whether Professor Marsh would like to elaborate on this, because I think maybe as a top neurosurgeon who's gone into writing about his experiences, so writing stories about the patients, how has that changed your approach? How has that changed your feeling about having been a surgeon and still operating? Has it changed it a great deal?
Well, my books, I've always kept a diary all my life, virtually every day. And my books really are a condensed form of my diaries. So that wasn't new. Certainly the General Medical Council in Britain, which is a government committee which supervises doctors, encourages young doctors to what's called reflective practice and encourages them to write a journal. I've always found writing a diary very helpful. It was a kind of emotional release from the work. And I think it is a good idea, but not everybody likes writing, you know. But I think it is a skill worth doing. And again, it's always this challenge of seeing our patients as complete people with their families. And it's difficult, but one must try. And of course, it does make the work much more rewarding. But as I said in my talk, in the early years of my career, I was defensive. I knew I wasn't that good. I was still learning my way, even as a senior doctor. But as I became more confident and I knew that I was actually okay, and I did not feel too threatened and jealous about surgeons elsewhere, I had a much easier, more relaxed closer relationship with my patients. But I think that's difficult at the beginning of your career because you are having to act and pretend to a certain extent.
I find that extraordinarily interesting because one of the points you made is that it's very important the senior doctor as a mentor, as somebody for the students and the junior doctors to learn from. So I think in answering your question, I think it's so important that the senior medical doctors, surgeons, show the importance of this humane approach to medicine, because students learn more possibly from what they see doctors and surgeons doing than from the classroom.
I completely agree. One of my big regrets, looking back at my career, was when I did outpatient clinics. And outpatient clinics are an incredibly important part of surgery. That's where you see the patients before the operation and see them afterwards. But I never had my trainees with me. I always saw the patients and their families on their own because I wanted to make it a completely personal, private conversation. In retrospect, that was a mistake. I think I should have sometimes had my trainees with me so they could see how I talked to patients, particularly about very difficult subjects like death and cancer and brain damage. So that was a mistake, and I regret that now, but it's too late to undo it.
Well, it's not too late because now this is what we do. So I think in a way,
sense, by lecturing, I try to undo it.
Been part of this.
Yeah. And in fact, handled properly, just with one or two students in the room with you, it's not very threatening. But if you have, say you have, I don't know, some intestinal, bowel, anal problem, and you or a gynecological problem, and you walk into the room and there are 10 medical students all looking at you, that is a horrible, horrible experience.
Okay, thank you. Thank you. This nice discussion. Professor Pera, he's a senior member of the upper GI and the general surgeon here. And I think in all that Professor Marsh was talking about, I think all very important points. I believe one of the most important points for me is the own knowing your own limitation. And I think this is crucial for a successful career. But some of the surgeons, some of the medical doctors don't believe this. You as a senior team leader, how do you approach this to your colleagues in a way? What is the strategy you use or would you use to let them know that they could go up to here, but from there on, they should not do it? How do you manage this?
Yeah, I think indeed part of your question relates to what Professor Marsh has said about teamwork. I think we all, or at least in my case, we at least explore our limitations, some kinds. Many times we need the opinion, the expertise of colleagues, and I think that it links very well with the idea of teamwork and have good colleagues, because it's the only way to improve our care to our patients, no? So during the training or as a senior, you have to, there is this component of teaching, or at least as a role model, try with your younger colleagues, your junior colleagues, to let them know that if they need help, they can ask for this help. But I think that all in all, it fits very well with the concept of teamwork. I think when, as said Professor Marsh, if there is a good environment in your team and you all discuss the cases freely, because the example he said about the airplane, sometimes also in the OR, it's very important that all members of the team make comments and are aware of what is happening in the operation, no? And you even need the opinion of your younger colleagues.
Thank you. Yes, I was privileged because I was trained in the UK, and Henry Marsh knows this. And during the training process, all the teachers met every year to evaluate the residents' performance. And after the second year, they would decide whether or not the performance was good enough for him to continue, or if they should choose or help him to choose another specialty. Not everyone is good for everything, and I think in the UK this was very well established. Here in Spain, once you enter the residency program, unless you go on killing people right, left and center, you will end up as a specialist. And I think this is not well looked after in Spain. That's why many people, when they have the title, they believe they can do anything about this, and I think this is a mistake. And I think this is one of the things I was asking Professor Pera about, because sometimes some of these residents, I'm not saying all, very, very few indeed, they come through you and you said, oh, this guy should not be doing this. And this is also related to the question to the student or next neurosurgeon to be. We've seen now what Professor Marsh has spoken to him, to all of you, saying how difficult was to him. He learned by his own experience. And it was unfair because he thought once when he was young, and he realized when he finished that he was wrong. Do you think these aspects of humanism and teaching how deal with death and patient care and complications, how do you transmit this information, should be included during the medical studies as part of a big subject, not only a one-year subject, psychology, we don't talk about this. Do you think this should be looked into more detail? What is the student's view on this matter?
Yeah, from my point of view, I think I'm going to be biased because this university does very well that. They introduce a subject based on that of the bad manners. But there's been a lot of times that we go to rotations, we go to surgery, for example, and we only see the part of the patient is going to be operated, for example. We didn't see the face, we don't know the case, the family behind that, and the history. So we only learn the practical skills, and we only see that part of medicine. But medicine is a lot bigger than that. It's about patients, it's about history, it's about when to operate, when to not operate. So by introducing this subject of bad manners, bringing bad news, seeing the patient, for example, something as simple as going to outpatient clinic, getting the history, the family, and then when you go through a surgery, it's so much different because you know the person, you know what he's going through. And also as well, for example, visiting the patient before surgery, the same morning at the 7 a.m. when you come, because we usually start at 8 a.m. on 9. But if you go 7 a.m., you can see the fear of the patient. You can relax them or reassure them. So I think it's very important for students, and I was not lucky to get into that subject because they started 2 years ago. But my sisters that are studying here now, they're going to be lucky to see that part of medicine, to understand that part. It's very important, not only the surgical part or the treating part in our specialists, but also the taking care of patients, because we're going to take care of human beings.
Thank you, Alex. I think you related well what is the humane part of the medicine, the technical part of medicine, which we all need to know very, very good, and those have to be matched beautifully. Now, I think this conference is reaching to the end, but maybe it's time to give a word to the floor. Somebody wants to ask any question, and of course, a neurophysiologist, you can stand up and ask a question and direct it to whoever you want.
I think I have a strong voice. Yeah, I'm not a surgeon. I'm very pleased about your talk.
You are
and not. I want to ask you a very simple question. You talk a lot about the present and the past. I want you to talk about the future. And I feel that you are a hardcore neurosurgeon, and I want to hear your opinion about functional neurosurgery and all these kind of strange devices that are put inside and from outside the brain to modify pathology and even to enhance personality. I want to hear your opinion about the future.
Well, it's always very difficult to predict the future. And I was not a functional neurosurgeon, though I have colleagues who are. I did psychosurgery many years ago in the days of lesion making for obsessional compulsive disorder. So I've always been interested in psychosurgery. But the fact of the matter is, we understand so little about our brains. 86 billion nerve cells, and even some of the most complex electrodes Elon Musk and Neuralink are putting into people's brains, they are still very, very simple. And they obviously have application for paraplegics, quadriplegics, movement disorders. But in terms of more complex psychiatric disorders and psychosurgery, I think it's unlikely there'll be much progress. There have been some big studies on deep brain stimulation for depression and dementia, and none of them have showed yet any convincing progress. So I don't know. I'm skeptical whether there'll be a huge progress, but you can never predict the future. I mean, on the whole, progress in neurosurgery is to make neurosurgery unnecessary. I became a neurosurgeon because I saw an aneurysm operation, and it was love at first sight. It was an epiphanic experience, and it took me about 15 years to become a reasonably competent aneurysm surgeon, and then over 2 or 3 years, it all went because of interventional radiology. So that may be the same for some of the trauma won't go away, spine won't go away, whether we'll have non-surgical treatment for gliomas and meningiomas, I don't know. But in terms of brain implants and computer-brain interfaces, there's a limit to how much we can experiment on people anyway. We can experiment on monkeys within limits, but otherwise people are already very damaged after strokes, trauma, spinal trauma, things like that. So I don't see a big future for implant functional work. I may well be wrong.
Thank you. Row 3 or row 4?
Yeah.
Stand up.
Sure. Hi. Well, thank Professor Marsh for your insightful presentation. It was truly interesting. I really wanted to try to go a little bit in depth, one of the points you mentioned about global cooperation, and ask you what's the current situations and what are the main barriers to have progress within this field. And also, I was really interested in the comments and remarks on the NHS healthcare system. How would you go about it, about this? Because you talked about management problems, funding issues, that there being this kind of fundings put in different buckets, and also something about culture, about this new generation culture, about the leaning more towards a work-life balance, leaning more for the balance part.
There are too many questions.
Yeah. If not, you can just answer the global one, which is probably the most interesting.
I'll talk a little bit about the National Health Service. I'm a great believer in what is called, the Americans call, socialized healthcare. There are always problems with it because it usually depends upon taxation, and politicians do not like raising taxes because they worry they will not win the next election. So there is always a problem with tax-funded healthcare. But in terms of equality and fairness, socialized healthcare is by far the best way of delivering healthcare. But there is this huge problem. We know about climate change and global warming, but there's a demographic crisis in the modern world. We are all living longer and longer, and there's more and more expensive medical technology. Think of CAR T-cell therapy for relapsed leukemia. It's about $500,000 to treat one patient. So all healthcare systems are struggling because nowhere in the world is economic growth rising more quickly than the rising healthcare costs. Everywhere, healthcare costs are rising more quickly than economic growth, so a larger and larger part of national income has to go on healthcare. And that is obviously a big political problem. And I don't know if you've been to America. I was a sort of visiting professor in America in Seattle for many years. I trained many Americans who came to work with me in England. American healthcare, in one sense, is the best in the world. In the other sense, it's a complete disaster in terms of it's got the worst neonatal mortality figures, the worst puerperal maternal mortality figures, the worst, it's got lower life expectancy than most modern countries. And yet it spends more money on healthcare than anywhere else in the world, both per capita and in absolute terms. So it's a disaster of a healthcare system because it's essentially commercial. It is driven by profit seeking. And medical, both doctors' decisions and hospitals' decisions are driven more by wanting to make money rather than by what is best for the patient. And the advantage of socialised healthcare, as we have in England with the NHS, is that the patient is the end. That is what we're trying to do. We're trying to treat the patient. Whereas in America and in private healthcare, alas, the patient is the means to the end of making money. And this inevitably leads to problems. But having said that, there are many, many problems in the NHS in England at the moment, and I see no easy answer to them.
Thank you, Henry, for the answer. Alex Del Arco wants to make a comment or a question. Can you address the question too?
Yeah, to the Professor Marsh. Thank you and congratulations for your talk. I think that your message is not how to be the best doctor, but how to offer our best version to the patients.
How to be a good doctor.
Yeah, and so your message was not how to be the best, but how to be, you sent us emotional and psychological introspective aspects to look inside ourselves and how to deal better with the other colleagues and with the patients, okay?
Yes.
But in our national system, educational system, for the last 50 years, which is called MIR for the residents, the only thing that is taken in account is the knowledge. Just a punctuation based on our curricular knowledge, and this is the only thing that we are measured, just to be a doctor. So are we really selecting the best candidates to be doctors?
Very good question.
Well, the answer is we just do not know what makes a good doctor. To become a neurosurgeon in England now, you have to go to a special program and your manual abilities are tested and you have to answer questions. But we still don't know whether this produces good doctors or not. And because there are so many different types of medicine, you need different types of personality. And if you look at the history, certainly of surgery, you know, many of the... I was in Istanbul last week talking, believe it or not, to the World Transplant Conference, but not about brain transplants. And Kate, my wife, and I were talking to a New York cardiac transplant surgeon who had trained under the legendary figure called Thomas Starzl, S-T-A-R-Z-L, who was the Mr. Big of liver transplant surgery and a hugely important person. But he had no home life. It is told he came home one day to find his wife had left him. His son said, well, he could have been a good father, but he became a great surgeon. And he was a wreck of a human being. But he made wonderful progress in transplant surgery. So perhaps we do need some people like that in medicine. We need a mix a mix of personalities. My old boss, who at Great Ormond Street Children's Hospital, who was a wonderful man, had worked for one of the most famous British neurosurgeons, a man called Sir Wiley McKissick. And my boss said, great surgeons have bad memories. And he said McKissick had this extraordinary ability just to forget bad results. My boss had to telephone him every night at 8 o'clock on the dot to tell him about how the patients were doing after the day's operating. And my boss said once he had to say, well, actually, Mrs. So-and-so is not doing well. McKissick had torn the vertebral artery, taking out an acoustic, and the patient had died. And McKissick denied all knowledge. He'd totally forgotten the patient. Selective memory. So perhaps we need a few psychopaths. And,
no, I think
we need good doctors. It's a mix. The answer is a mix, and we don't know.
I think, Henry, what Alex was saying, related to what you answered, is that in England, for instance, you never are selected by a number. You do an interview.
Yeah, no, sure.
And I think that, that can file you towards if you're going to be a surgical doctor or non-surgical doctor. I think the aspect of having an interview is good to decide whether or not he's going to be good at this or not. And a simple number is certainly not the way to select what's going to be the best candidate for
I was an examiner for neurosurgery for the Royal College of Surgeons for many years, and we had a real battle with the educational psychologists who said interviews were biased. You know, we would judge people by their sex, by the colour of their skin, by the way they spoke. But we won the battle and said, actually, you know, in an interview, you really get a pretty good idea of whether the candidate, what they're like, what they can do. And the solution is to have many interviews.
Absolutely.
So we'd have about 10 pairs of examiners, and then you collect all the marks together. And the remarkable thing was almost always the examiners agreed. So the oral interview, I think, is a very important part. But it's difficult with kids, you know, with teenagers and their unformed personalities. But I agree, a number is a bad idea.
Just one comment about this is that, unfortunately in Spain, I think it's not the same in England, the medical students start training for the mere exam in the third year, fourth year. So sometimes there's a feeling, I get this feeling, and I'm, as you know, not a doctor, that the education is biased towards just passing an exam and not making them good doctors.
Towards a multiple question mark. This is not even medicine. It's just to fill in what's the question mark going to be correct in 5 samples. Okay, well, I think we are reaching to the end, unless there's any burning question.
I have a confession to make.
Okay, there you are.
I forgot my last slide.
Oh, can you put ¿Puedes poner la charla otra vez, por favor? They took it all out already.
No.
They'll put it back on.
Oh, good, here we are. Yeah. So I must zip. Right, well, yes. I'm often asked, where's it coming on the screen? Yeah, I'm often asked, what advice would I give to young doctors of the future? And I have a very simple answer, which is, ask for help. And secondly, good luck. Thank you very much.
So thank you, Professor Marsh, for your splendid lecture that I think make us, it's a way to stimulate and have a reflection about our practice, and mostly when we have many students from our School of Medicine here. So thanks a lot. Also thank you, Alex Godot, that our former student, Jonathan McFarland, and Jesus for all what you did for for having Professor Marsh with us today. So thanks a lot.